Well, good afternoon, everyone. Welcome to another Samaritan's Purse International Health Forum. Delighted to have you guys with us today and just hope you're doing well. As is customary here at the forum, if you would just look at your chat box to the right of your screen and sign in your name and perhaps where you're from. It's always exciting for me just to see where everybody is located and tuning in from around the world. So again, glad you're with us. Have an exciting presentation for you today. Before we get started, we're going to have just a quick prayer. So bow your heads with me. Dear Heavenly Father, we just thank you for Samaritan's Purse International Health Forum, the opportunity to learn more, to serve others, all for the opportunity to deliver the gospel, to bring the gospel, a message that's just desperately needed to be heard around the world. Lord, just speak through Dr. Faber today. Thank you that she can be with us. In Jesus' name, amen. So, well, I'm just delighted to have Dr. Kelly Faber with us today. She's going to be presenting Caring for the Premature Infant in Low and Middle Income Countries, Creating the Silver Standard. Dr. Faber is a pediatric hospitalist who completed medical school at the University of Louisville and then her residency at Cosair Children's Hospital, which is now referred to as Norton's Children's Hospital. She completed that in 2011. After she completed her pediatric residency, she then joined Samaritan's Purse post-residency program, where she served in southern Togo at Hospital Baptiste Publique from 2012 to 2014. Dr. Faber then proceeded to join ABWE, a full-time medical missionary, as a full-time medical missionary, and she returned to Togo, but in the north, to serve at Hospital of Hope. She remains there now serving full-time, where she continues to work as a hospitalist, and she is currently running the pediatric hematology oncology program there, referred to as Surviving Takes Hope. And she does specialize in neonatal care. Dr. Faber's other experiences also engaged with Samaritan's Purse in the past, including program management for infection prevention and control, during our response in DRC during the Ebola outbreak, and she's also helped manage response to Lassa fever there in Togo. Dr. Faber is currently getting her epidemiology degree, or excuse me, her master's degree in epidemiology at the London School of Tropical Medicine and Health. So, Dr. Faber, you are a very busy doctor, and we are most appreciative to you for taking time out to present Caring for Premature Infants in Low and Middle Income Countries, Creating the Silver Standard. So I'll turn it over to you.
Thank you, Lance, and thank you to everyone who just joined today. I'm pretty sure there's a lot of familiar quote faces, if you will, people I've worked with in the past, and maybe some people who've even been here to Togo with us. And so if you've been to Togo, you know we take care of a lot of premature infants here, and we're going to talk about a silver standard, a term maybe I've coined, I don't know, but I call it the silver standard. We can go to the next slide. There's our objectives. We're going to talk about food requirements and balance in preemies, growth charts, how to follow those, current practices for feeding and supplementation, what can be done when mother's breast milk just isn't enough to get these little ones to grow, and different problems and solutions that we can do for them. Next slide. So what is the silver standard? Everybody knows in medicine what the gold standard is and what that means. It's the best, and these have been established in almost from all of our board's questions results, from the gold standard, what tests to do next, what treatment to do next. The problem with the gold standard for most of us in LMICs is that these have been developed through high-income countries' medical practices, and they're often not available to us. The question remains, are they even relevant or translatable to us? Things like the FEAST trial that came out have shown us that maybe the way we treat sepsis in the high-income countries actually don't apply to us in low-middle-income countries and may even be dangerous. So what is the silver standard? This is a need to create something in our minds so that we can avoid the idea that something's better than nothing. This can happen a lot in missions hospitals or other LMIC settings where at least we're there doing something. And we want to kind of get away from that. We want to meet the specific needs for specific populations. Our neonates in Thailand, if some of you are in Asia, they might not be the needs for what we're doing for our kids in Togo, but the Silver Standard wants to say what are the differences and what we can do to find what these differences are and meet the needs unique to our situation. I know when I worked in the Southern Togo, nutrition is very different for moms there. They don't have problems with malnutrition in general. And when I moved to Northern Togo, I thought, I know how to do this and we're just gonna keep going. But things were very different here because our maternal population is very malnourished here in the northern part of our country, which is affecting our survival rates. The Silver Standard is also just a way to outline attainable goals for care and survival. We want all of you, I want all of you to be able to look at your programs, look at what you're doing or you haven't started yet and say, what's the next best thing that I can do with the resources we have, or maybe some with a small amount of funding, what could we do next to improve survival? Next slide. Here in Togo, I just want to give you a view of what we have and don't have so that you don't think we're running kind of this major high unit, and in some ways maybe we are. We have a lot of incubators, probably 10 or 15, but only one of them is working. We do have a lot of high intensity phototherapy units available to us, probably greater than 8. If you need a link to where we get those for cheap, let me know. IV pumps we normally have, but just so you know, right now we only have one working. We do have inline oxygen. We also can blend oxygen and air. We have Cpap. We don't use bubble Cpap right now, but that would be a better standard. We do have access to surfactant. We place UVC lines, that's umbilical venous catheter lines, and we do have a 24/7 running lab that includes cultures and lumbar puncture CSF counts in most labs. What we don't have is we don't have ventilators, we don't have TPN, we don't do blood gases on these babies. So that gives you a little bit of view of where what our capabilities are here. Our survival rate. So we consider viability over 600 grams, which just means that's who we're going to resuscitate. Every one of you will have to kind of create a line in the sand of who you put your resources towards. And for us, it's over 600 grams or over 26 weeks or spontaneous respiratory effort with a good color and cry without fused eyelids. So that's what we've decided to be as our cutoffs for who we're going to resuscitate. Right now, we only follow, as far as statistics is concerned, babies who are born under 2 kilos, and our survival rate is about 92% for those. Very low birth weight infants, which we'll talk about what that means for us, is survival is 80 to 85%. Extremely low birth weight infants for us is about a 10 to 15% survival at this time. Next. So really, this talk is kind of part one of many. Neonatal care is a very huge topic that cannot be covered in this amount of time, so I'm choosing to focus on part one, if you will, which is nutrition. The fluid requirements for babies is really the biggest focus that needs to happen when if you're going to decide to take care of low birth weight infant babies or premature infants at really any level of prematurity. The normal day one fluid need for a newborn is 60 mils per kilo per day. You're going to hear this all the time. You're going to get annoyed by the mils per kilo per day. It's all about math and a calculator. You really can't take care of neonates without a calculator. And we start with D10W, that's no sodium in the fluids, for preemies at 80 mils per kilo per day. Their fluid requirements are going to be more from the very beginning. You might be using fluids anywhere from D5 to D15. I would say that's a little bit of a typo. Anything greater than D10 should really be using a UVC. If you're finding that D10 is not enough for your little ones, you can run it through a peripheral line, but it's just, you're going to run out of peripheral lines. It's going to destroy their sites. So you can try if you can, but it usually doesn't go well. Calcium gluconate is usually a given that all preemies need to start on as part of their fluids. We actually do not do that. unless they have a UVC for similar reasons of we usually can't keep IV fluids going well with calcium added to it through a peripheral line. So we end up losing those lines too much, and then we don't have access anymore. But if you're able to do calcium, then that is a recommendation. Really, the neonatal care ends up being very methodical, which is good. It helps being able to teach people, especially that are not physicians, so that some of your higher level nursing or other people can end up learning these protocols. You end up increasing total fluids by 20 mils per kilo per day, and that is a pretty fixed rate, and we'll talk about different reasons for not doing it. But starting at day 1, that means it's 80 per kilo per day. Day of life next is 100, and then 120, 140, 160, and it keeps following. And we'll say when to stop and when to not. It is a guideline opposed to a rule because we'll show you different weights that you need to follow of when you shouldn't do this. But if all is going well, you want 20 per kilo per day increase, and this could be by fluids of any kind, whether it's IV fluids or feeds, as we'll talk about. About 48 hours of life, you want to make sure to add some sodium into those fluids. We make our own IV fluids here at the hospital, or the majority of them. So we choose D7.5 quarter normal saline. You don't want to do anything over quarter normal in that neonatal period if you can help it. If you have access to quarter normal, that would be the fluid of choice. And you want to stay away from potassium if you can in fluids for similar reasons of most LMICs. We're not regulating our rates very well. But if you're not feeding a child within 48 hours, then you want to think about either following potassium levels or going ahead to adding just basic physiologic needs of potassium in the fluids. Next. Why would we want to increase this total fluids? There are all situations where you know your baseline is 80, but that even from maybe day of life 0, you want to go up from 80 right away. And that's if an infant's under a radiant warmer. You might even need to increase by 50% depending on what your situation is. I know many have homemade incubators that are using light bulbs that have a lot of heat that ends up dropping babies' weights very quickly because of insensible losses. Phototherapy. Uncontrolled dry environments. Here in Mongo, Togo, during the months of our dry season, our humidity drops to about 10%, 15%. And usually this is definitely affecting the fluid needs of our babies. Of course, if they have obvious issues like gastroschisis and phalloceal, those are major issues that many of you aren't necessarily dealing with at your centers. Why would somebody need less fluid? We'll talk about this more in depth. Abnormal weight gain in the first 7 days of life. So anyone that deals with normal newborns knows that there's a dip in the beginning of neonatal life. We talk about return to birth weight by day 10 for a normal infant. That loss of fluid is actually extremely physiologic and necessary. And when it doesn't happen, babies have an increased risk for necrotizing enterocolitis. I would guess it might be a problem for some of you in these countries trying to work with preemies, is that maybe we're trying to push fluids too heavy and too fast and not allowing babies to drop at first out of fear that they're going to lose too much weight. But that initial weight loss is actually a very important, necessary thing to happen even in our preemies. And of course, if they're poor respiratory status, sometimes we have to, we can't give them the fluid that they need. Don't forget that it's total fluids per kilo per day that need to be calculated, mils per kilo per day. Don't forget that this includes feeds, fluids, and sometimes your IV medications. We don't always, I'll admit, do a good job of considering our IV medications here to increase in our fluids. But if you have a very sick child that is in a lot of IV fluids and has a weight of, when you're starting to talk about 800 grammers or 1 kilo babies, some of these medications, depending on what your hospital's ability to dilute or not dilute to give, can really add into fluids. So if you have a baby who you think the fluids are right, but their weight is going up way too much and you don't know what it's coming from, it could be all the medications they're on. Some of you might just need to start to weigh your babies daily. That is a necessary thing. Step one that is usually low cost measure that these babies need to be weighed, because every decision you're making about their care is going to be based on that daily weight. The other caveat is that calculations that you're going to be doing, it's birth weight until day of life 10, no matter what. So if you're still using and you're starting to calculate off of some of that that weight loss that's happening early on, or inappropriate weight gain early on, that's really going to mess with your fluid balances. So calculate based on birth weight all the way through day of life 10. Next slide. So of course we know that fetal nutrition is usually parental nutrition, and in a perfect case scenario that these babies would continue to get parental nutrition, even in the form of TPN. But know that a fetus at 28 weeks only has 20% of their calcium and phosphorus, 20% of their fat, and only a quarter of glycogen stores. So it's easy to see right away how far off the bat we are when these babies come early and the difficulty we're going to have. Next slide. Of course, the dilemma for most of us is that we don't have TPN. I haven't heard of any LMICs, especially missions hospitals, having TPN. If you do, that's amazing. But most of us don't. So our goal has got to be starting feeds as soon as safely positive, so that babies don't start to break down their own protein and muscle mass in order to get amino acids. Back in the day, even in high-income countries, it was thought these preemies got like starved for 2 weeks at a time or a week at a time. It was thought not to feed them early. But more research is showing that the earlier that these babies can start feeding, the better, and that's going to be our goal. Next. So the classifications that's going to be the baseline of our feeding protocols are low birth weight infants, which are less than 2,500. For the purpose of this, we usually use a cutoff of less than 2 grams, or not 2 grams, 2 kilos, because our average weights of our babies here are about 2,300 grams, 2,400 grams. That's kind of a normal full-term infant for you, for us here. So you'll have to look at that for yourselves. Very low birth weight infants is anything from 1 kilo to 1,500, and extremely low birth weight infants are anything under 1 kilo. Preterm infants are anything under 37 weeks, and then your late preterm definitions are 34 to 36 and 6, 7 weeks. As I said, only for our purposes, our pediatric or medical service only follows babies that are under 2,100 grams. Otherwise, all other infants are followed by our normal newborn midwifery service. Next. So these are the feeding protocols that we use. These are out of a book that it will be at the end of the slide. It's written by David Adamkin. I'm partial to it because I was trained by Dr. David Adamkin, but he really is, not just because he happened to train me, but he really is one of the leaders in early neonatal nutrition, and literally kind of wrote the book on the idea of feeding these babies as early as possible. So if you look at this, I do think this chart is a little bit confusing. I wish in an updated copy he would change the way this is written. I mean, you might have to change it for your, and you can rewrite this. But this is for babies under 750 grams. This might not apply to some of you where you work. But the way it's reading is that it says day of feeding. It's not day of life. It's whatever your first day that you started feeding, you were able to start. 1 mil times 6 feedings a day. So it's a weird way to think about it, but it's Q4 feedings, because every 4 hours you get fed, that would be 6 feeds a day. This first 3 days is actually called trophic feeding. It's a way to prepare the gut and kind of tell the gut that something's going to be coming. But these 3 days, you actually don't calculate into the total fluids. So trophic feeds do not get calculated into total fluids at all. And then by day 4, you're going to start Q2 hour feeding. So it's 12 feedings a day. That's Q2 hours. So it can be very labor intensive. I encourage you to teach moms from the very beginning while they're doing Kangaroo Care to go ahead and participate. Otherwise, it's way too nurse heavy, and most of us don't have the nursing staff to do feedings for these kids every 2 hours. So don't be scared to teach your moms how to do it. And as you see, you just follow going down. So in this protocol, every single day, they're going to go up by 1 ml every 2 hours until they get to full feeds. Next slide. The next category is greater than 750 and less than a gram. So you're still going to have a trophic feeding time, but it's going to be a little bit more. So your first 3 days of feeding, it's 1 ml every 2 hours right away. But once again, those first 3 days are called trophic feedings. They are not calculated in your total fluids. They're just there to prepare the gut of the infant. And then the protocol advances from there. The last protocol on the next slide is going to be from 1 kilo to 1,500. Next slide. This is going to be maybe where a lot of you live as far as if you're starting to do preemie care. And this is day of feeding. Like I said, maybe not day of life 1, but the first day that they start feeds. You're going to get 2 meals, 8 feedings a day. So 8 feedings a day translates to Q3 feeds. 2 meals Q3, the next day is 5 Q3, the next is 8 Q3. These protocols, as you can see, are based on 1 type of increase of feed per day. I know many hospitals I've seen are so in a rush to kind of start feeds that they're going up many times per day, maybe 2 Q3 and then 5 Q3 and then 8 Q3 in kind of the rush to get to full feeds. But that can really increase your risk of neck. So if you're saying, I'm trying to take care of preemies, but a lot of our preemies are dying from neck, that could be a reason, is that feeds are advancing too fast. Next slide. So when should we start feeding these babies? All these protocols are just based on day of life 1, but it's for you to decide when day 1 is of feedings. No matter how little the baby is or what weight they are, if the child had a routine resuscitation, no complications. So no cardiac compressions, no epinephrine, did not need prolonged positive pressure ventilation. Of course, as a routine, most of these babies are going to need 2 to 3 minutes of positive pressure just until we get everything set that they need to get oxygen prepared and everything. I wouldn't necessarily not feed a baby because of that, but it really just depends on your APGAR scores. So if you have a second APGAR that's 5 or less, I would not start feeding on the first day because that child's more at risk of HIE and other issues that are going to come into play. But if they had a relatively routine resuscitation with a second APGAR that's higher than 5, then I would highly consider starting feeds on day 1 if mom has milk. You want to wait at least 24 to 48 hours if an infant required significant resuscitation or is showing signs of sepsis or shock or of any way. That infant's gut is not going to be ready and their blood flow to the gut is not going to be prepared. They're going to be shunting blood flow away from their gut to their brain, to their heart, to make sure their kidneys, to make sure vital organs are working. So you don't want to stress that by adding feeds to the gut at that time. We used to only start feeds when babies were off of Cpap. I'm just going to put based on your comfort level. In the US, babies are fed on Cpap, but it really just depends on yours. If I have a child that I think is really just on a little bit of prophylactic Cpap, maybe they're 29 weeker and I'm just putting them on Cpap from the start, I'm not going to start on day 1. I'm just going to see how it goes over the next 24 hours. But at the same time, if I have a baby who's on day of life 5, and who has not come off of Cpap yet, they need to start feeding. So I'm going to go ahead and start the protocol because otherwise they're at other risks that are going to be worse than starting low dose feeds at that time. So you'll just have to work with what works with you and what your comfort level is and how long has the baby gone without feeds. Next. A word about NG tubes. NG tubes are relatively easy to get. I'm not saying you all have them, but if you have access, I would say all premature infants need an NG. If a baby's on oxygen, leave that NG open. Even if they're on feeds, go ahead and finish the feeds. You can even try to dangle the tube up using some string if you want to, or be creative if feeds are kind of coming back. But you want to leave it open to try to keep their bellies from filling up with air in the gut, and you just want to be able to vent the babies that are on oxygen. For Cpap babies, I always do an OG because otherwise you're creating a gap in the nasal Cpap. So OGs are best, but just know that I For OGs, you want to make sure that your nurses should be verifying placement before every feed, but especially OGs, because babies start to work those out more with their tongue. So you really want to make sure that your placement is right before feeding using those OGs. Just a word about taping NGs. Try not to tape upwards on the nose. Our staff likes to do that sometimes where the tape goes up and across. Babies' noses and nasal septums in prematurity are very at risk, and that ongoing pressure can actually cause a necrosis through the nose. So try to actually tape to the side. And I know that some of our hospitals don't get choice at what kind of tape we get, but just be careful with the tape. We have one type of tape we have that we cannot use on baby skin because, especially in the heat, it gets so sticky that it ends up ripping their skin when you take it off. So paper tape works nice, but just choose your tape wisely. Tegaderms work really nice for babies actually as well. Next slide. So here's where we get into the math. So courage, and I know some of you are just shaking your head right now. But neonatal care really is all about the math. And as feeds are being introduced, according to the protocol, those total fluids need to be calculated each and every day based on weight gains or losses. Like I said, reminder, birth weight's used until day of life 10, but then at day of life 10, you can use their actual daily weight. So we're just going to go through an example. If a birth weight is 1,350 grams, feeds started on day of life 1. Date of birth is day of life 0. Just keep that in mind. Birthday is day of life 0. So on day of life 4, the EBM, that's express breast milk, that's what we use for express breast milk, so this is maternal breast milk, is 11 cc's every 3 hours. So that would equal 88 mils per day. But you want to know how many kilos per day that is. So you're taking the 88 mils per day, dividing it by the baby's kilos of 1.35. We're using birth weight because he's only a day of life 4, and that's going to equal 65 mils per kilo per day of feeds. But at this point, you want the total fluids to be 160 mils per kilo per day. So you're now taking the 160, you're subtracting what he's going to be getting with feeds, and it's going to leave you with 94.8 mils per kilo per day. I'm going to encourage you not to round your numbers until the very last. Because especially when you're dealing with very tiny babies, some of those little decimal points matter. So just try not to round until the very end. So now you know you need 94.8 mils per kilo per day left for the IV. You multiply that again by the weight, and you're going to get 128 mils per day. You divide that by 24 hours, and then you get 5.3 mils per hour. So that's what your IV rate is going to be. So this baby is going to have 11 cc's, probably through an NG every 3 hours, and their IV rate is going to be 5.3 mils per hour. Just a word, I know I've talked to some of you, I'm sure already, about feeding and different challenges you guys have, and one of those is that you don't maybe have IV pumps. That's become an issue for us lately because a bunch of ours kind of broke all in a row, and we were down to 1, and we had about 9 neos at that time. So we had to get creative. If you can at least get your hands on micro drips, those are extremely helpful and can protect babies and can make counts of drips that your nurses are making a lot easier. Macro drips are very hard to manage for preemies, so that might be your next step, is maybe getting your hands on micro drips. Puritrols also are small containers that actually hook up to a bottle of IV fluid so that you can only keep maybe 50 cc's in at a time. I know accidents happen, especially when we're dealing with drips like this and not pumps, and babies can end up getting bolused with massive amounts of fluid if you're doing micro drips, or if a mom touches the IV rate and all of a sudden a bunch pours in. So a Puritrol is a way of protecting a baby from getting an over bolus at a time. So if you don't have IV pumps, I realize how frustrating that could be, but you can also try to get creative. I know someone we talked to at a hospital in Asia, we talked about maybe just doing 6 hours of fluid on, 6 hours off, 6 hours on, 6 hours off. So you're actually calculating your total fluids based on 12 hours of time instead of 24, because that's kind of what they can do. but just know you want to do what you can in order for that 24 hours of fluid to get in. And that's what you want to focus on. Next slide. Just remember that fluids and calories aren't the same, of course, and these preemies usually require 120 kcals per kilo per day. So now we're switching from mils to kcals. So a neonate who's getting 120 mils per kg per day, so we think of an infant's at least baseline fluid needs in order to kind of keep up urine output is probably at least 120. But mother's breast milk is 20 kcals per ounce. So if you take 120, and then you end up doing the math, you end up needing, that 120 is only 80 kcals per kilo per day. Most preemies will end up needing at least 120 kcals per kilo per day to start growing, not just 120 mils. So there's a difference between a baby staying hydrated and a baby having enough calories to grow. So yes, a baby can stay hydrated on 120 mils per kilo per day, but you'll need to get that all the way to 180 mils per kilo per day of mother's breast milk in order to meet the 120 kcals per kg per day calorie requirement. So keep that in mind, mils and calories of what a baby's getting at any given time. Next slide. So what we do here is we have to work on fortification. Fortification is something that happens obviously in high-income countries. You think about formulas like Neosure, which is 22 calories. Mother's breast milk, like I said, is 20 calories per ounce. But usually we are going to hit a problem with volume. These preemies are not going to be able to grow, and they're going to max out on volume where they can't tolerate any more volume, and they're still not growing. So we have a situation where we're going to need to fortify. The way we do that here is we use infant formula to fortify EBM, and we use sunflower oil. Next slide. So I'm going to talk about sunflower oil, and some of you might just need to plug your ears and sing a song for the idea that you will not, sunflower oil is researched and studies as far as using topical use. Some studies have said it can reduce sepsis up to 30%, and as it decreases insensible free water loss, it can actually be detected in the bloodstream as far as increasing triglyceride levels in the baby, even as it's absorbed through the skin, especially in extremely low birth weight babies. But systematic reviews and others using other oils like coconut have very mixed reviews. We've decided to use them because we think the risk outweighs, the benefit outweighs the risk. And there's actually a few good studies that show the help that they can use. You can start using immediately after birth. We do twice daily sunflower oil to the skin. It's something that helps moms be involved and not be necessarily scared to touch their babies, as sometimes we employ the moms to go ahead and do oil massages with their babies either twice a day or 3 times a day. The problem though is that babies are missing out on a fat requirement, and usually obviously lipids are given through TPN. Our moms are usually very malnourished here, and so their breast milk is usually very lipid low. The requirements for a preemie are 1 to 3 grams per kilo per day. Sunflower oil is about 1 gram per mil of fat, and our protocol is to start PO sunflower oil once they're on 100 mils per kg per day of the EBM. That's not just of total fluids, but that's actual feeds, and if they're needing more calories. We don't start at PO automatically if they're growing well, but if they need more calories and we need a place to find them, that's what we do. That's where some of you need to plug your ears, because that is not a studied thing to do, but we've been doing it here for probably the last 8 years or so. But it's something that it just know it's out there, that someone else is doing it. But some of you might need to know that is not a plug or a studied thing or something that I can say is a normal standard, but it is how we get our babies to grow. Next slide. This is a chart. You can find it. I'm not getting paid by Inflamil, but Inflamil has a really good chart that if you can even Google it, that talks about supplementing mother's breast milk with powdered formula. So we use local formula sold here in Togo, and there's a chart of how to supplement it. I think it's easier to do by percentages, so it's 22 calories is 2.8%, 6.2% is 24 calories, all the way up to 30 kcals. So this is where you're taking mother's breast milk, you're taking a volume of powder, not prepared, but powdered, and then you're adding it to the breast milk. So when I take, we'll go through an example, but if I want 26 kcal, that's 10%. So if I'm feeding a baby 30 cc's, that means 3 cc's of dry powder is going to be added to that mother's breast milk, and that's going to make 26 kcal milk for that baby. Next slide. So if we have that same preemie who weighs 1.35 kilos and he's on 35 mils Q3, and he's not tolerating his feeds well because he's vomiting after 28 mils, what can we do? So I'm sure this is a very familiar thing to anybody who takes care of preemies in any country. So that 35 Q3 is 280 mils per day. Whoops, I ended up changing my weight somewhere in here. Sorry. I went from 1.5 to 1.3. But that ends up being about 207 mils per kilo per day. If we go into calories, then we divide it by 30, multiply it by 20, because that's what mother's breast milk is, and this baby's at 138 kcals per kg per day. But if we add 1.5 cc's of dry formula to 25 mils of EBM, we're going to get 24 kcals. So now my volume is going to be 224, and that's going to be 166 mils per kilo per day. And the calories are almost the same, 133 kcals per kilo per day. So I can get less volume, but equal calories if I just fortify. Next slide. Sometimes mother's breast milk is not 20 kcals per ounce, which is a problem, but you can actually check the hematocrit. So most hospitals or clinics use capillary tubes for their hematocrits, and you can actually just collect mother's breast milk, make sure it's well mixed and not sitting for a long time where kind of the cream is separating, and collect 2 tubes and you can spin it down. This is in a book that's at the end. This is the Global Child Health by the AAP. They have a great explanation of how to do this in that book. So I recommend looking at it. Next slide. And then you can actually see, using the hematocrit, what are the calories from that mom. So you can see that second star down. If your mom is only producing 15 kcals milk, then you know when you're fortifying, you're not actually fortifying to what you think you are, and you might need to fortify more in order to get the calories you need. Normally, in a mom who's well nourished, they found that mothers of preemie breast milk is actually high calorie already, that a mom's body knows that she needs to make more. So sometimes you test your moms and they are actually naturally at 24 kcals already, which is awesome. But sometimes they are low, especially if they're malnourished. Next slide. This is the typical feeding position progression of babies. You'll look that usually they don't get a nutritive suck until about 32 weeks. And usually in the States, they don't really reach good sucking and coordinated suck until about 35 or 36 weeks. Next slide. Our protocol is we start PO trial feeding at 32 weeks. This is early compared to US standards. We give them 30 minutes. And after 30 minutes, no matter where they're at, the rest of the feeds are given NG or OG. Our average age for full PO feeds is around 34 weeks. This is an instant where the silver standard of feeding is actually beating the gold standard, as it's pretty rare in the US for babies to be full POing by 34 weeks. So this might not be true where you are or your babies, and it would be interesting if someone else was doing this to see what other people are getting, but on average, usually for us, the 34-week mark, kind of their brain turns on. The earlier a baby is born, the earlier they're going to feed. If I have a 28-weeker, then usually they're going to PO feed by 34 weeks, 100%. But if I have a 33-weeker, they're usually not going to PO feed until about 35 and a half, 36 weeks. So brain maturity kind of matters based on how long have they been out of the womb. So the earlier they're out, if they're surviving, the earlier that they're going to actually meet some of these milestones. Next slide. We're just going to go through some growth charts. You can go to the next slide. There's different growth charts for preemies. We use the Fenton growth grids to know where we would be, let's just say, compared to the US. So even though we can usually not meet these very well, it's still a good way to see where we are. And especially if a mom's willing to keep up expressing even after discharge, how poorly are we doing or how well are we doing about where the standard should be for those weights. So I encourage you that even though we're not usually meeting these standards, it's still good to know where we're at, and you still need to be able to track these preemies as outpatients as they go on over the first 2 years of life. The Fenton goes until the 50-week mark. Next slide. Get good at Ballards. As we know, most of our moms are not getting echoes in the first trimester, and so you really want to be able to get good at Ballards to know where you're going so you can start to track some of these babies and their survival, what they should be doing based on their gestational age. If their reported dates for us are within 1 week of a Ballard score, we use patient dates. If they have a first trimester ultrasound, go ahead and do the Ballard so that you can actually just practice and improve your skills until you kind of get good. If you're at a place that is really good at doing early ultrasounds in your moms, go ahead and Ballard even some normal babies so you can get used to practicing this, because it can really come in handy when you have a mom without dates, because you don't know if your baby's an SGA. You can't just go at average weight. Oh, well, he's 1,300 grams. He's probably a 29 weeker or 30 weeker. That's really hard because there's so much SGA in these populations. So you don't want to just go on weight to determine gestational age. Next slide. So this is a curve that I would encourage anybody in a hospital or clinic setting to use. I call it the Danton Curve because that's who first published it. It's actually from 1953. And this is what we use to know how we're doing. This curve was developed to look at what is adequate growth when TPN is not available. So this is what we use to know how we're doing. Especially in the first 7 days, we want that dip to happen. If you can do better than this chart, great, meaning if they're growing better, then you want them to let them grow better. But you especially want to use it for this first 10 to 15 days because you don't want them to be dipping lower than the number they're at. If they're 1 kilo, you don't want their weight dropping less than 900 grams because then you're really falling too far off the curve. So this has really helped us, and you weigh daily to see what you're doing. And we're going to show some examples. Next slide. So what's wrong with this curve? So this curve is bad because he's 1,500 grams. The lowest he should ever be is 14. But right away, he started, actually even from day 1, started to fall off this curve. So what would we do? So on day 1, let's just say he was at 80 mils per kilo per day. Normally, even if he was following his curve perfectly well, we'd be going from 80 to 100 mils per kilo per day on day life 1, no matter what. But now he's gone too far down. So this is a case where going from 80 to 100 is not going to meet your goal. And so this is a mistake a lot of people make. They think, oh, we lost weight, but it's okay because we're going from 80 to 100. 80 to 100 is the normal progression, even if your weight is right on point. So you're going to need to go another 20 per kilo per day to make up for the too much loss that you had. So even on day 1, you should have gone from 80 to 120. This person probably didn't, and now they're still kind of, okay, well, now we'll go from 100 to 120, 120 to 140. But really, they think they're going up in fluids, but they're really not. They're actually just following the normal progression of fluids, and they're never catching up. Next slide. Things that are going to be excessively weight loss in the beginning is what I just said. They're not really catching up like they did. Reasons for that, for excessive weight loss, especially after day of life 5, are going to be sometimes these kids have PDAs. Always think of sepsis, late onset neck, just not enough calories opposed to your volume, just poor calories, and anemia. Next slide. Now this baby never lost the curve. And so this is a problem. Even at day of life 3 is that first one. He should have gone down. So what should have happened after day of life 1, where he was at 80 and he should have gone to 100, he should have stayed at 80, because you still want fluid loss. And this kid, almost every time I see a graph like this starting, you should be very nervous about this child going to have neck or some kind of sepsis, that something else is going on. If you're at day of life 20 and this baby is jumping up the curve, passing lines, awesome. That's going to be great, but you don't want to see that jump early on. You really want to hold down on their fluids and think of what's going on. Next slide. Definitely don't increase by 20 ml per day in a neonate who's not had the diuresis. This is a major mistake that's happened. These babies don't do well. Like I said, neck is the most common. A persistent PDA could be the reason for this. I wrote, we won't talk about it, but you can refer to this slide of just what we use for dosing for attempt of PDA closures, because we do not have surgical PDA closure here. But you always want to think you're missing something or not doing something right if that weight's going up early on. It's not a good thing. Next slide. Other things for milk supply, our moms have horrible milk supplies here. Kangaroo Care, you could do a whole talk on Kangaroo Care. Make sure moms are drinking at least 3 liters a day. Make sure if you can get hand pumps or actually machine pumps, that's a great way to increase supply. Breast massage while they're pumping, and then for better or for worse, we end up having to use a lot of Reglan. But if you're in an area that has moringa is a great natural way to improve milk supply as well. Next slide. We do iron, but no iron until day of life 14, and or they're on full feeds. You want to wait on that. Don't start it too early. Your dose is 2 to 3 elemental milligrams per kilogram per day. Vitamin D is also necessary, 400 units a day. If you can get polyvisol, we try to get it donated here, or some kind of generic equivalent, of course. That would be the best. Next. Just make sure that if you're following these babies up once they make it, that ideally if they're fortifying at discharge, you want moms to try to fortify as long as they possibly can. Ideally, it would be for the first year. We've never had a mom agree to do that. They usually switch over to breastfeeding alone, and then their weights really don't do as well. But if a mom's willing to do it, sometimes we try to get them to EBM, express breast milk during the day, and then breastfeed at night, knowing that night is a harder time, of course. We see our babies every week for 2 weeks, and then we space it out gradually until it's Q3 months for up to 2 years old. That would be the goal. Just a success story. Ruth, she was born at 26 weeks, 650 grams. She's our youngest one to make it. She's 9 years old this April. So it really is possible to help these little ones survive. Don't get overwhelmed by it. Just try to think of what's the next best thing you can do, the next step. It's hard to do all these things at one time. So just kind of think through things. Maybe it's just graphing your baby's weights, right? They just need to be graphed and weighed every day. And that's a major thing that can help you know what you're doing. So don't get too discouraged. Next slide. So just what can you add without any extra resources? What other resources you have now that can already change the way you're feeding babies? And what would you need as a resource to make you the next step? Is there a small amount of money, small resources that you need that you don't have, whether it's NG tubes or what? So start to think through these things, and please feel free, even after this, if your questions don't get asked, please message me, contact me. I'd love to talk to you about your situation specifically, where you're at, what your resources are, and what we can use what you have to kind of make the next step to helping these little ones survive. Thank you very much.
All right. All right, Dr. Faber, thank you so much. I'll be honest with you, as an internist, that was an intimidating presentation. But nonetheless, it was fabulous. It was fabulous. I need to learn certainly a lot more about pediatric management and certainly with regard to premature babies. But I have been to Hospital of Hope in Togo, and I will say that Dr. Faber and her colleagues do a remarkable job with limited resources. So I certainly applaud you for that. Kelly, I am glad that we have some questions here. I will start off. Marvin Haig asked, when and how did you get surfactant?
Yeah, I'm shameless for asking for donations from companies. So we get InfoSurf from the InfoSurf company, and they donate it to us as long as we keep them updated on babies we use it on and success stories for them. But yeah, reach out to companies and ask. This is where you are. InfoSurf is second line in the United States because it causes clogging of ET tubes. So it kind of fell out of favor here. But of course, our babies aren't intubated, so it's not an issue for us. So we get it donated about twice a year.
Great. Thank you. Cindy Utley asked, when you're calculating total fluids, do you also subtract for blood draws?
We don't, but I did have a slide in there that I took out because of time. We do not do a lot of lab draws on our babies. When they're born, we do a 6-hour CBC, CRP, and a Budapest from a malaria smear. Mm-hmm. Sometimes they get a 1 ml blood culture. And then we're really not doing other labs. The only standard labs we do on our babies is we do a once-a-week hematocrit, and we transfuse for any hematocrits under 30. But we're not doing the routine blood draws that everyone's doing. And I can't say that I think that any of our babies are worse for the wear, unless something specific or you have a EKG issue and we're getting lights, but we're not doing these daily blood draws. So it's usually not an issue for us.
Right. Yeah. Thank you. Cindy Kitchen asked, how did you determine the rate of tube feeds of 160 per ml per kg per day?
For that one, maybe I'm not going to understand your question well, but I was just picking a number, thinking that if that baby's 4 days old, if he was at 160 mils per kg per day, so you're always starting at 80. Unless, let's just say I'm starting at 80, but I'm starting phototherapy right away because the groupage is ABO incompatible. So right away from day of life 0, I'm going to start at 120. So I'm going to do the 80, and then I'm going to add 20, knowing the baby's on phototherapy. And then from there, I'm just going to base it on that. If that baby's following the line on the Danton Curve, I'm just going to go up by 20 per kilo every day. I will say you really want to try to avoid going any higher than 180 mils per kg per day in fluid only. Once you get over an 80, you really want to try to think about your other fluids being added in as feed fluids. So once you get to that point, even if they're on Cpap, even if they're looking tenuous, you want to think about starting to add that 2 mils Q3 or something rate in there. So normally, uniformly, you're going 20 per kilo per day. But if you're on phototherapy and you're on Cpap, on day of life 1, you might be starting at 140 per kilo per day already because of the other things happening. But normal is you always, if they're following a good curve, is it always go up by 20 per kilo per day.
Great. Thank you, Kelly. Marvin, again, he asked, can you comment on the different caloric levels of breast milk, for example, Hind milk calories?
Yeah, Hind milk. My mentor, Tina Slusher, is ringing in my ears right now talking about Hind milk, and she should be shaking her head. You know, we don't do Hind milk well at our hospital. Hind milk is definitely higher in calories. So if that is one issue. If you don't want to fortify or if having a hard time and mom's breast milk supply is enough, then surely she can actually express for 5 to 10 minutes. Maybe don't dump it, but put it aside and then have her finish until emptying, and then feed Hind milk first. And then if that volume's too low, supplement with what she got in the fore milk. Hind milk is always going to be higher calorie. The reason we don't necessarily do it here is because our moms really have nutritional issues. And a lot of times we're struggling to even meet the volume with all of it being emptied. The other thing is make sure that when moms start to express from the very beginning, that they're emptying every time. So sometimes you don't want to tell moms how much you need, because if you say, we just need 2 mils, they're just going to express 2 mils and give it to you. And then the body's going to get very confused. So make sure maybe don't tell mom how much you need. Just make sure she's emptying each and every time. Otherwise, you're going to have supply issues. But if mom has enough milk, high milk is always going to be higher in calories than 4 milk for sure.
Great. All right. Noted. Thank you. Just a comment from Debbie Lambert with regard to Enfamil supplement chart. She just stated that some countries' local available formula powder is less than the formulas Enfamil and Similac. So make sure that you check the calorie per nutrient content. You may need to self-calculate how much to add based on the given formula that you use. Thank you, Debbie. Cindy Kitchen also asked, do you make your own TPN from coconut or other substances if you don't have materials available, or basically only tube feeds?
No, we do not do any kind of TPN or IV nutrition. I think, my mom used to make TPN and, under a hood, and it's quite a thing, and end up being how fast you have to use it. It can be a high bacterial load because of fats in it. And so we've never gone down. And a lot of times, unless you're willing to do major labs all the time to follow and adjust all the time, it's really just kind of a black hole of resources to me. I will make a comment about coconut oil, though. We started giving oral oil based on the fact that babies in the States get MCT oil. And MCT oil is medium chain triglycerides. So it's not like I'm totally reinventing the wheel by giving sunflower oil PO, because oil is given to babies in the States. I tried coconut oil early on, actually first. That used to be what I did when I first moved here. But our babies did not tolerate coconut oil. They just spit up all the time. So it was a little too heavy for our population here, but if you can get it and it's a good clean source, then coconut oil is another option for oil feeds, but our babies don't tolerate it.
All right. Thank you so much. The last comment, just our question is, can you list the book or books that you mentioned, Kelly? So what we can do maybe is after this presentation, we can get that list from you. And when we provide our follow-up email, we'll include that list for you guys.
I think it's on the last slide in my references slide. I think I listed both those books that are great.
Okay, great. Yeah, we can send that in our email. So Kelly, I think that's everything. Again, we really do appreciate you taking time from your schedule there, and it's great to be able to host this, and have you presenting from Togo. Thank you so much. We really appreciate everything you do for the people of Togo and beyond, and your ministry is incredible. And so we just really support you. I just want to remind our listening audience that there will be a follow-up email with the recording of this presentation. Of course, there's CME, and there'll be instructions on how to access that CME. Just encourage you to do that. And again, just if you want to join the forum, you just go to health.samaritans.org, and you can sign up and attend these regularly. Just want to remind you, there's a whole host of archives of previous presentations and that also have CME available to you. So really take advantage of that. Our next webinar will be Wednesday, March the 10th, with Dr. Terry McGinnis. Dr. McGinnis will be speaking with regard to a COVID-19 update regarding vaccines, immunity, and long-term sequelae. So do stay in tune with that. And with that concludes our presentation. Thank you, guys. God bless.